Dr. Tarun Madan, Associate Professor in Cardiology at UNMICRC Institute of Cardiology, Ahmedabad. So today we'll be discussing about venous interventions. Venous problems are a huge chunk of vascular disorders. We have upper limb, lower limb veins getting involved in various kinds of diseases. Starting from the upper limbs, we have subclavian vein, axillary vein, and superior vena cava, which can get occluded. So axillo-subclavian vein thrombosis is a majority of patients coming to the OPD with upper limb DVT. It can be secondary due to catheters, indwelling IJV lines, subclavian lines, pacemaker leads, or it can be primarily because of the stress-induced Paget-Schroeder syndrome, which can give rise to thrombosis in the thoracic inlet part. Axillo-subclavian vein thrombosis we can manage either conservatively by giving oral anticoagulants. They can be VK antagonists or NOACs, apixaban, dabigatran, rivaroxaban or edoxaban, or vitamin K antagonist in the form of warfarin or acetrom. Secondly, you can subject these patients to catheter-directed thrombolysis. Catheter can be inserted either by ultrasound guided from the cephalic vein or the basilic vein, or from the femoral venous access into the subclavian vein, and you can spray or inspissate the lytic drug at the local site. Lytic drug can be in the form of either alteplase, urokinase, streptokinase, reteplase or TNK-TPA. You can either do balloon angioplasty also if required, and then crepe bandaging to reduce the swelling. Coming to the superior vena cava syndrome, we should always look for the cause, whether there is an inside thrombosis or extrinsic compression. If there is an extrinsic compression, it can be because of the malignancy, or it can be because of any tumor, or it can be because of the chronic kidney disease patients having a fistula in either the left upper limb or the right upper limb, which is created to do the frequent dialysis. And these patients already have received some or the other time IJV cannulas, subclavian venous cannulas, permacaths, and then because of the chronic venous inflammation, they can come up with SVC syndrome or innominate vein, axillary vein, subclavian vein thrombosis. Similarly, in these patients also catheter-directed thrombolysis, which is known with the acronym CDT, oral anticoagulants, novel oral anticoagulants as discussed apixaban or rivaroxaban, then balloon angioplasty, and if required, you can put a stent in the superior vena cava. These stents can be self-expanding stents or balloon expanding stents. Balloon expanding stents have good radial strength. Self-expanding stents have large diameter available, but they have moderate radial strength. Coming to the inferior vena cava obstruction, it can be because of the DVT extension from the iliofemoral segment up into the inferior vena cava, and the part of vena cava or the whole vena cava can get thrombosed. And it can also happen because of a IVC filter which the physician failed to retrieve and the filter got occluded. Sometimes there is a rare condition called membranous occlusion of vena cava at the junction of right atrium and IVC, which also can behave like IVC syndrome, and the patient can have abdominal distension, dilated veins in the anterior surface of abdominal wall, ascites, lower limb swelling, and weight gain. This can be very detrimental and disgusting for the patient. So relieving the obstruction and managing an antegrade flow from the vena cava is very, very important. Extrinsic compression in the inferior vena cava can be because of retroperitoneal fibrosis, which is a very, very deadly disease and difficult to manage. So again, these patients have medical therapy, catheter-based therapy, balloon angioplasty, and dedicated stents like sinus XL or sinus venous. Coming to the iliofemoral deep vein thrombosis, these patients present with swelling of the one leg or the both legs depending on the iliac veins, which are the outflow from the leg to the heart, and when these veins can occluded, there is massive swelling and edema and pain and redness in the affected limb. This can be idiopathic, or this can be because of any secondary cause like sedentary patient in a post-operative condition, because of the malignancy, and because of some hypercoagulable states. We can do catheter-based therapies with the help of CDT. When we put a catheter into the popliteal vein, patient is to be turned in a prone position. Will come later in the pictures. and then under the ultrasound guidance, you take a popliteal venous access and do the CDT. Different agents are available depending on the affordability of the patient: urokinase, tissue plasminogen activator, TPA, retaplase, alteplase, which is same as TPA, and tenecteplase, TNK-TPA. And then you can sometimes do, in chronic DVT cases, balloon angioplasty or iliac vein stenting also can be performed. Mechanical therapy in these patients of iliofemoral DVT, different devices are available with the name of Tralis, which is a balloon occlusion catheter, Angiojet, which is a mechanical rheolytic thrombectomy device, and ECOS, which is an ultrasound-based catheter-directed lysis system. Coming to femoropopliteal DVT, which involves only superficial femoral vein and popliteal vein, they can be managed conservatively with bandaging, oral anticoagulant, novel oral anticoagulant, catheter-directed thrombolysis, or balloon angioplasty. So now we come to few cases which we have done so far. This first image is of a patient who had inferior vena cava occlusion in the hepatic and infrahepatic segment, but the suprarenal portion was totally occluded. So a femoral venous access was obtained, and as we can see, the inferior vena cava was having blunt occlusion into the hepatic segment, and then there was a lot of collaterals surrounding. So a sharp recanalization method was used with the help of broken bro needle, and it was gained entry to the right atrium. Once the distal true lumen was confirmed, a Inouye balloon catheter was used to dilate the inferior vena cava, and good antegrade flow was established, and then a strong balloon expandable stent, rigid stent, was deployed at the IVCRA junction to have a long-term antegrade patency. So stent can be seen in the first picture, and the follow-up CT angio of this patient after 6 months shows a well-placed stent, good patent lumen of the inferior vena cava, and no migration. Lifelong this patient needs to be given anticoagulant, and there was immediate resolution of ascites, edema of the legs. Now this picture shows how a CDT is carried out in a iliofemoral DVT. Patient is lying in the cat table in the prone position. The left popliteal vein has been cannulated with the help of ultrasound guidance, and a fountain catheter, as seen in the first picture, which has multiple holes. It is parked in the iliac and femoral vein, and urokinase infusion is given slowly over a sustained period of time, so dissolve the thrombus. Now this is a female who had left leg massive iliofemoral DVT. What is the cause of DVT? There is an endothelial injury, there is abnormal blood flow, and there is hypercoagulability. This is a classic varicose triad which leads to thrombosis. So we have to manage each part of the triad. Now this lady has a chronic DVT, chronic venous congestion, which leads to eczematous changes in the anterior part of the leg in the skin, and if not treated well in time, this can give rise to a non-healing ulcer, as is seen in the second picture. Right side, there is a non-healing ulcer which is big enough to cause debility and chronicity of the patient. It increases the morbidity of the patient. And the veins in the legs have valves which open in one direction. So once you have a clot formation, there is damage to these valves also, and you land up in a post-thrombotic syndrome or persistent edema of the leg. So to manage that, we have bandages, either the venous bandages or crepe bandages, to continuously guide the patient by bandage therapy. So this is a patient who had membranous occlusion of inferior vena cava. We can see in the first cine there is stagnation of blood flow in the inferior vena cava, and there is another catheter from the jugular access right IJV, and we are trying to pierce this with the help of a sharp recanalization technique of transseptal puncture needle, broken bro, and then once it was confirmed that we have reached to the right atrium, we did a balloon angioplasty, and this angiogram now shows very good antegrade flow into the right atrium. Patient's ascites, dilated veins immediately disappeared. This case was done way back in 2011. It's 12 years now. Patient is still having a patent inferior vena cava, and he is on anticoagulants. Now coming to another set of venous cases which have chronic venous occlusion in the iliac vein. This is a disease which is known by the name of May-Thurner syndrome. Now the first scene shows the patient has inferior vena cava and right iliac vein patent, left common iliac vein is totally occluded, and left external iliac vein drains with the help of few collaterals. Now in the second picture we can see there is very good antegrade flow in the left common iliac vein after the balloon angioplasty. So this patient underwent only balloon angioplasty, but if required we can go for stenting also. So don't wait for a longer period in these patients of vein disorders. Early resolution of symptoms and prevention of post-thrombotic syndrome is the key. Lifetime or at least 1 year to 2 years of anticoagulant therapy if it was a predetermined cause, that bed rest caused the DVT, and if the patient is ambulatory, then you can stop the anticoagulation very soon. Thank you so much.